Welcome everyone to the Sign IGOT Limb Deformity webinar. It's going to take a few minutes for everyone to get onto the call. So while we're waiting for everyone to join the webinar, we're going to go ahead and launch a poll. So a poll should pop up on your screen asking you about your experience with limb deformity. Thank you to everyone who is joining for the Sign IGOT Limb Deformity webinar. We're really excited to have you. Just showing you the poll results so you know who all is joining. It looks like we've got a group from around the world, but the largest contingent joining us from Africa. So good afternoon or good evening. It sounds like the majority, about half, have had no formal training in limb deformity, but there are a handful who have had more extensive training. And seems like the majority are seeing limb deformity in some volume, some more than others. And actually a majority of people at least sometimes have access to ring fixation. So that's good to hear because that will be discussed a fair amount throughout this talk. So we're going to go ahead and get started now. We'll begin with an introduction from Dr. Lou Zirkel from Sign.
Thank you for joining our webinar on limb deformity. The principles of limb deformity can be applied to fracture reduction, and all of us are interested in giving our patients better results. So the principles of deformity correction can be used also in fracture reduction. So I'm grateful to all of you who attended to reach out, learn new skills to become better surgeons who give their patients better results. This deformity correction symposium is composed of basic principles, limb lengthening, and bone transport. And our speakers are from Portland, Oregon, Cleveland, Ohio, Nigeria, Kenya, and San Francisco. So thank you to all of you for attending, and thank you to all of the panelists.
Thank you, Dr. Zirkel, for the introduction to the webinar. My name is Dave Shear. I'm here in San Francisco, and I'll be helping to moderate the session. This is the schedule for the course that Dr. Zirkel mentioned. We'll begin now with a talk by Dr. Rich Gelman on the basic principles of deformity planning. We'll then have a didactic lecture by Dr. Ray Liu from Cleveland, followed by a case discussion led by Dr. Izuagba from Nigeria. We'll finish then with a didactic on bone transport by Dr. Ken Thomas from Anchorage, Alaska, and a case discussion led by Dr. Anthony Maina from Kenya. Next slide. I just want to remind everyone throughout the webinar, I'd love it if you submit any questions that you have using the Q&A button, which will be at the bottom of your screen. Not only can you submit questions there, but you can also do thumbs up for questions that others submit that you would also like to hear answered. So please take advantage of that Q&A button throughout both the didactic lectures and the case discussions. And we've got a fair amount of time set aside to try to address those questions. So please use the Q&A function. The last thing I wanted to mention before we get started is just that both the full recorded webinar will be posted both to the IGOT portal and the Sign Hub. So please take advantage of those resources if you want to go back and see any of this material again. So again, we're going to start now with a didactic lecture by Dr. Rich Gelman from Portland, Oregon. Thank you.
Hello, and welcome to the Sign IGOT Limb Deformity webinar. And good morning, good afternoon, or good evening, wherever you are in the world. I'm Richard Gelman, and I'm pleased to start off the academic session with talk on limb deformity, planning, sawbones frames, quick TSF overview, and then leading into cable transport. What method do you use? Paper and pencil, an application like Bone Ninja, intraoperative guesswork with your fluoroscopy or a clinical observation of the deformity or something else. So traditionally for paper and pencil, you sketch the deformity, you draw an anatomic axis on the diaphyseal segment of the bone and joint standard axes in metaphyseal bone. You calculate the apex of the deformity at the intersection of those two lines. Then you select the level of osteotomy. You cut the paper at number 5 and then rotate the distal fragment to align the proximal and distal axes. So the joint reference angles are the Baltimore numbers, and x-rays are oftentimes not the full hip to ankle x-rays to measure mechanical axes. And so using the anatomic lateral distal femoral angle of approximately 81 degrees is going to be your easiest way to measure. For the proximal tibia, it's 87 degrees on your medial proximal tibial angle. And then at the ankle, 89 degrees or about 90 degrees. So the joint angles method, here you've got a tibia, so your medial proximal tibial angle of 87 degrees and your lateral distal tibial angle of 89 degrees. And that's using just joint angles. Here you can use anatomic axes, the little way of going mid-diaphyseal, 2 mid-diaphyseal lines separated by at least 4 centimeters, and then their intersection. And then the lateral 2 pictures, they would show a combination. For proximal tibial deformity, use a joint axis reference line, and then your intersection with the anatomic axis to create your medial proximal tibial angle. And then if you simply subtract, the 74 measured there from the 87 standard, that gives you your angular deformity of 13 degrees. And remember osteotomy rule number 2, that means there's going to be secondary translation as long as you're rotating about your cora or your apex, okay? But you've set your osteotomy not through the center of the cora. So here's a quick clinical example of a valgus long-standing deformity of the tibia, no deformity in the femur. And here we have a proximal joint reference angle and a mid-diaphyseal line distally. Post-correction, you see that secondary translation, but the straight mechanical axis of the bone. On a more complex deformity like this femur, so it would indicate a multi-apical deformity. Here I really like the flexibility of using a Bone Ninja app. And then, in the proximal tibia, that deformity is a little great to correct acutely because she also had a significant rotational deformity. And here's our post-correction. Clinically, you really are following nicely your plan. Here's a straightforward valgus deformity, but interestingly, it was a segmental, but just focusing on the mid-diaphyseal deformity. Here, this shows osteotomy rule number 2 and some challenges, which as long as you understand that's what you're going to be looking at, you can adapt to. So here, if the osteotomy is above the level of the apex, maybe due to soft tissue reasons, chronic infection, poor soft tissue coverage, you're going to get a secondary translation here. It would give you an opportunity to sort of dock the distal segment into the canal proximally, but would leave you in a situation where you would want to maybe do a planned bone graft to fill in that medial defect. But if you're able to modify slightly the location of your osteotomy, as in the distal, or as in the example on the right, you've got almost a small pure opening wedge that should fill in very quickly. So here the osteotomy is made as close as possible really to the deformity. Your osteotomy line goes through the cora, but we've also angled that osteotomy to be more parallel, to be more sort of perpendicular to the distal segment that's moving. And so because of taking as little bone off that medial side as possible, we really minimized any bump or minimize secondary translation, and also the size of the medial bump. Take this example, where that osteotomy is made, distally, about 1.5 centimeters distally, and that enormous translation and remodeling, as well as that large medial prominence. So in summary, careful planning leads to better outcomes. There is less secondary translation and cosmetic deformity, better stability at osteotomy sites, more rapid healing of regenerate bone, and the ability to use a nail instead of a frame sometimes. So use lots of paper or tries on the iPad. Let's talk about frames now. This is the Sawbones frame that I set up. I've placed the bone defect and fracture non-union site at the proximal tibia. So this is a reverse bone transport of the tibia. You can see you've got 3-ring frame, and to grow the regenerate bone on the lower segment, okay, we are going to use straightforward controlled axial elongation of that segment. And we're going to use either clicker rods or 4-sided nuts as shown on this frame. And then around the non-union side, the side with the bone defect, we're using Taylor spatial struts so that we can gain, correction of any other deformities at the non-union site. And so here's a focused view on the 4-sided nuts versus the clicker rods. The 4-sided nuts are obviously very inexpensive and easy to obtain. The clicker rods are less common and more expensive. Remember, for the 4-sided nut, it's the segment below the 4-sided nut that's moving upward. And so you're going to loosen, lefty-loosey, the upper nut and advance the lower nut 1/4 of a turn, or, 1 dot to 2 dots every 6 hours. For the clicker rod, remember, it's centered in between or around the osteotomy that's distracting. It's fixed above and below. And so here you'll teach the patient to push in the little tab of the clicker rod. So as time goes by, that's rotating in a clockwise direction if we're looking at this tab the way we are. And that affects the distraction at the osteotomy site. So for fixation, I emphasize, if you're at the proximal or distal end of the bone, those are your strength rings. That's where you want your maximum stability. So I always recommend, if it's a single ring construct, 4 points of fixation. On the upper segment here of the proximal tibia, we've got 3 half pins and 1 wire. You can see you get optimal spread of fixation with the transverse wire, and then at 90 degrees, a half pin that's going right into the bone of the tibial tubercle. So very solid fixation just from that. And then 2 more oblique half pins. In the distal tibia, I've got 3 wires and 1 half pin. So once again, excellent spread of 90 degrees. And there's not a fibula in this Sawbones model, but when there is, we always put a posterior lateral to anterior medial olive wire to gain really solid fixation. And then in the moving segment, 2 to 3 points of fixation, depending on 1, the length of the moving segment, 2, how solid the bone is. If it's very strong bone, then you can often just use 2 points of fixation. Or if it's a short segment, 2 points of fixation. And so now we've got our Taylor spatial quick overview. For those new to using the spatial frame, this is the first screen where you give the case information. You select anatomically the segment of bone and where it sits in the bone. You create a case log. Often if you're at a small hospital, you can use the patient's medical record number. If you have a large office, maybe your office number. And then any case notes that you want in the case, like is it an infected non-union. Then here is where you tell the computer the deformity in the bone. So it's just like you would read off an x-ray. AP view will show you a varus or valgus angulation and or a medial lateral translation. Lateral view, apex anterior or posterior deformities for angulation, and then anterior or posterior translation. And then axial view will go with angulation, which is internal irregular rotation, and translation is sort of axial translation is lengthening or shortening. And if you click this box at the bottom, you can apply axial translation first. So like the classic thing is, before I start to correct a complex angular deformity, I'd like to just get the system going and get the bone ends separating so that the bone ends don't start to prematurely consolidate, impinge on one another, and prevent angular correction. Here, you're simply telling the computer what you put on the patient. So you've got proximal and distal rings, size, as well as shape, because you can have a 2/3 ring, or you can have in foot corrections, U plates or other types of rings. Then here you just click the box that says what struts you're using. In this page, you're going to tell the computer where the center of the ring is in relationship to the origin. It's so that it can do the math to correct the deformity. So if you center your ring in the coronal plane, and this yellow tab marks the center of the ring, and it's centered right in the center of the bone, and you've chosen your origin to be the center of the bone down here, in your AP offset 0. On your lateral offset, and I made a model here, the center of the ring is right where this wire is, and then the center of the bone sits about 10 millimeters and to the front of that wire. And so here I did a ruler with this Taylor spatial strut. You know, you're about 50 millimeters from front to back, which means the center here of the bone, you can just bring that straight up. So, you know, you're looking at within the ring. So you say the center of the ring is, and then you measure this distance, 10 millimeters, okay, posterior to origin. Does that make sense? Because here's the center of the ring and here's the origin. Your fifth screen is going to do the actual calculation, do the math. So when you first go to it, you fill in your strut settings that are on the model in front of you. You click the blue box that says calculate final settings, and then the numbers come out here. If we want to correct a deformity but are concerned about some aspect, so just hypothetically, if I didn't want to stretch the perineal nerve coming over around the fibular head, I would set my yellow dot here, 35 millimeters, okay, lateral to the origin, and about 40 millimeters proximal to the origin, because that's where the nerve would be the shortest, would be the tightest. Then I hit a calculate, and it gives me the number of days to run the program. It prints out the program, and you give this to the patient. So I appreciate that was a very quick overview of how the software works. I hope it was beneficial to some. And now I'm going to move on to something that we touched on briefly the last time we came together at a sign conference, which was a cable transport, which we set up on a distal femoral diaphyseal non-union site model. And so there's a great article here by Dr. Quinnen, and that is, he's out of Miami, and he did a great job in the article showing you everything you need to create a cable transport, as well as a sawbones cable technique for you to practice on. And you'll see how it looks on the model that we have. So thank you very much for your attention on this formal portion of the Zoom conference, and looking forward now to the interactive portion.
Thanks so much, Dr. Gelman, for that. Was a really great talk on an introduction. If all the panelists can turn their video on, that would be great. I just wanted to, we're going to launch a quick poll just asking about how people do their preoperative planning. And Dr. Gelman, I was wondering if while people are doing that poll, if you would just speak to your thoughts on the importance of preoperative planning and what recommendations or thoughts you have on using paper versus an app or some other electronic version.
Sure. I really can't emphasize enough the importance of the pre-op plan, and you will, can you hear me okay there?
Yes, yeah, your audio
okay.
is great.
You'll hear this emphasized in the courses in Baltimore and around the country, but you saw in those couple examples, you know, if you play with where you're going to make your osteotomy and the angle, and then do your correction, it can really speed up the healing time of your regenerate bone if there isn't a lot of shear at that at the correction site, at the place where you make your new bone formation. And yeah, I know that Dr. Emeka has many examples of these complex deformities, and I'm sure he can verify this along with other experienced users. So that's my real point, is play with either your paper and pen, or if you have access to a Bone Ninja type app. I know that a lot of the software systems have built-in deformity correction software.
Great. I'm curious to hear from our international panelists. Dr. Uzwagba, what do you like to use for your preoperative planning? Are you paper and pencil, or you have an app that you like to use?
Yeah, I actually like using the apps. I have the Multiplier apps and I have the Bone Ninja. It's quite easy and handy. Can always carry it around and
Great.
even show it to my residents and colleagues.
That's great. Dr. Mina, do you have any comments on how you like to do your preoperative planning?
Yeah, for me, most of the time it's paper and pencil.
Paper and pencil.
Yeah, exactly.
Yeah. Okay. All right. Great. Well, again, it looks like the Q&A is a little bit quiet right now, but if anybody has questions, now would be the time to fire those through. I think what we'll do is get going with our next didactic lecture, which is going to be by, see, we're seeing the poll results now. It looks like the majority of you are doing paper and pencil. But perhaps if there are questions about some of the apps like Bone Ninja, we can provide some information on that after the webinar. I think in the interest of saving time for some of our case discussions that are going to come later, we'll move on to a talk now on limb lengthening by Dr. Ray Liu.
Okay, so this is a talk about limb lengthening. So starting with the clinical exam, there's a few elements that you want to get on the clinical exam that you can't necessarily get in x-rays. The first is the ligament discrepancy to decide what size blocks to use on your x-ray. And this is best done by having a patient level on stand on blocks and level their pelvis. For a younger child, you can measure them supine. You want to know their hip abduction, adduction, and flexion contractures, whether they have any knee flexion contractures and whether they have any equinus. All of these can change the apparent limb length discrepancy. You also want to know the rotational profile so that you know what to do in terms of correction of the femur and tibia. So hip internal versus external rotation gives you a sense of your femoral anteversion and retroversion, and thigh foot axis as well as thigh malleolar axis can give you a sense of your tibial torsion. It's very important to know what the maximal knee extension is, whether they have a fixed flexion deformity or hyperextension. And I do like to push their popliteal fossa into the bed and then extend their knees to really get a sense of what the true extension is. Oftentimes I'm doing my sagittal plane correction based on the clinical exam rather than the radiographic parameters, or incorporating both of them. It's very important to know if there's any laxity of the knees. So that has to be carefully examined. Then you have to protect joints that are loose. You also want to know if you have any dynamic thrust that influences whether you correct genuvarum or valgum. So all these are important clinical exam parameters that you can't always get on an X-ray. What about the X-rays? Well, the classic is to get a standing AP hips to ankles with a lift under the shorter limb so that the pelvis is as level as possible. That prevents the patient from bending their knees or doing other things that alter the view. You also want to get a maximum extension lateral if possible. If you can't get a full length, you just get as much of the femur and tibia as you can. And you do want to try and force that maximal extension so you have a sense as to where the patient is clinically. In terms of skeletal maturity, bone age is classically done with the hand X-ray. Because we are treating limb length discrepancy, we always have knee X-rays available. And we just recently published an article in JBJS just this last episode with a knee skeletal maturity system that outperforms glucompile. So hopefully this will be useful going forwards. In terms of making your limb length discrepancy predictions, the rule of thumb that you can use very easily in clinic is that boys grow to 16, girls grow to 14 years of age. The distal femur grows 10 millimeters while the proximal tibia grows 6. And then you can do your estimations. You have to understand that this is less accurate in younger children. So children outside of the pubertal age range, this might be less accurate. And you have to account for whether they are congenital versus acquired. So it's not always as simple as it looks, but this is a great rule of thumb to use. The Moseley straight line graph is an excellent system. It does take a little bit more time to draw out your patient's visits on this, but this works in an excellent fashion. There's also the multiplier method, which is useful in that you can make predictions based on a single visit, and you can do so fairly quickly because there are apps out there that allow you to do this quickly in clinic. In terms of treatment options, the classical charts that people have put out there, this one has from 0 to 2 centimeters, no treatment. From 2 to 4 centimeters, a shoe lift versus shortening, and greater than 4 centimeters lengthening. But this article, which I helped write, did state that because of the changing dynamics of limb lengthening with internal lengthening nails changing the balance, the threshold for lengthening will most likely become lower and lower with time. And these numbers will continue to change. A prosthesis is an option out there, although these can be fairly expensive prostheses. So what are the general goals? We want to level the pelvis so that the takeoff of the lumbar spine is vertical. We also want to, in some cases, leave the leg a little bit shorter if we have something like a stiff foot, where it's the shorter leg will be easier to clear in swing if it's a little bit shorter, or to allow some length for bracing. So you have to consider that for some patients that you might want to leave them a little bit short. And at the same time, you definitely want to fix other deformities. In terms of the tools that we have, drill epiphyseodesis is a very common one for epiphyseodesis surgery. Some people prefer to put screws instead, oftentimes citing that this has less morbidity because you're not drilling and irritating the knee as much. In terms of the benefits of lengthening over shortening, the patients oftentimes have a better long leg, and the idea of doing surgery on it is concerning to them. You get to simultaneously correct deformity generally when you're lengthening, and oftentimes that's an important factor. You get less issues with prediction errors because the biggest issue with epiphyseodesis is that you can have a prediction error and end up with more limb length discrepancy than you would like. And then you get a greater overall height if you lengthen, and that's important for a lot of patients, particularly boys. It's important to consider that there's a period of time between 4.5 and 6 years of age where you generally do not want to start lengthening. This is a time when children are very difficult to deal with, and the challenges of limb lengthening can really become overwhelming during these time periods. Physical therapy is critical throughout lengthening. It's very important to emphasize and arrange if the patients are not doing it. so that you can keep them out of the operating room and away from releases and manipulations like in this patient. For the femur, the unilateral external fixator is oftentimes very helpful because a circular fixator oftentimes can irritate them given the location of the quadriceps. In the tibia, I do prefer to use a ring external fixator. You have a large amount of subcutaneous bone to work with to get multi-directional fixation in these. The magnetic lengthening nails have really changed the dynamics of limb deformity correction over the past few years. These are very expensive nails, unfortunately. So what are some of the techniques? We'll start with the basic proximal tibia external fixator. This is a technique that was taught to me by Dror Paley, and I continue to use it. It's I first place a guide wire from the proximal tibia into the proximal fibula. I pass a 3.2 millimeter cannulated drill, and then place a 4.5 millimeter non-cannulated screw to fix the proximal tib fib joint. This avoids having to put a wire across, which the wires are often irritating. I use a similar technique for the distal tibia fibula screw, although I generally nowadays place the screw going from the fibula towards the tibia, just to avoid the saphenous vein. Then I separate the fibula at the midshaft, and then mount a tension wire and a 2/3 ring on top of it, oriented in line with the distal femoral condyles. In the AP view, I then add a 2-hole cube and place an anterior half pin to set it in the sagittal plane. And then this sets the proximal fixation. To augment the proximal fixation, I then add 2 additional half pins coming at 90-90 angles from anterior medial and anterior lateral. And you can see they're built off of a 1-hole cube and a 1 1/2 hole cube, essentially, by putting a thick washer in there. And this allows you to stack those top 3 pins and get a lot of fixation within a small amount of real estate, so you can break the proximal tibia as high as possible within that metaphyseal, better healing bone and closer to the level of the deformity in most cases. And then add the distal fixation as well. And then the tibia can be separated with drill holes and an osteotome. And again, trying to stay as high as possible. So you can see the final construct here. This is a different patient who had a congenital femoral deficiency in fibular hemimelia. And this one I treated with the unilateral external fixator. And you can see here that because we're going to protect the joint and span into the tibia, I'm placing a guide wire at the rotational axis of the knee, which is where the posterior cortex intersects the growth plate. An arthrogram is helpful to help define the cartilaginous bony outline. And then the entire fixator is built off of this. So the distal half pins are all built off of that first dummy wire. It's important to place all of these pins in the posterior half of the femur. If you place them anterior, you're at risk of iatrogenic fracture. And then you can see here the construct with the hinge going down into the proximal tibia. And if the hinge is placed properly, generally the patients can move this very well, and it does not bother them too much. And they should have good motion throughout. And here's a girl with good healing after 5 centimeters of lengthening. For the same patient, oftentimes with fibular hemimelia, they have eversion problems because of the deficiency of the fibula. So this is a guided growth plate to purposely tilt the tibia into additional varus distally to help improve that eversion issue. This is a different patient that had a traumatic growth disturbance. And you can see some Procurvatum deformity there. And so for this one, you can see that we mounted half pins angled to each other in the sagittal plane to correct that Procurvatum deformity. So when a straight bar is placed within those pin clamps, then you get a straightening of the bone and extension correction. And this is her after lengthening. This is a patient with a pure limb length discrepancy. So in this case, we did an internal lengthening nail. And again, these are changing the dynamics of lengthening because of how much more patient comfort there is. There is a slow move towards shorter and shorter lengthenings being acceptable. This patient at 12 weeks has good healing and excellent range of motion. This is the I believe the last case I have here, this is a 12-year-old female that has a limb length discrepancy and fibular hemimelia. And the important thing here is that you have to span into the hindfoot. You have to protect that ankle joint because of the fibular hemimelia. And so here you can see our lengthening. And here I made the mistake of taking off the hindfoot fixation too early and not having enough fixation in the ankle, which caused a non-union and required bone grafting. And so it did eventually heal, but did require that additional time. And you see I added a half pin to get some more stability there. 3 years later, you can see that they're reasonably balanced between the two sides. So it's a talk in of itself to go through all the different complications that you can have, but this lists some of the main ones. Pin track issues are almost ubiquitous when you're doing external fixator-based lengthenings. Mechanical failure can certainly happen. You have to be very vigilant, especially about the struts or other moving parts impinging. Malalignment can definitely occur, so you have to be careful about monitoring them radiographically. Non-unions, certainly. Premature consolidation can happen if you do not lengthen fast enough in the beginning. I generally do a week of consolidation and then lengthen at about 1 millimeter in the femur, and usually between 0.5 and 0.75 in the tibia. Fracture can certainly occur. You have to be very careful about injury to adjacent joints and protect when necessary and stop lengthening if you're starting to get into issues. Nerve and artery damages can occur and are catastrophic, so you have to be very careful about that. And then growth inhibition can also occur, so be careful about lengthening more than 5 centimeters in a young child. Thank you very much.
Great. That was a phenomenal talk, Dr. Liu. Thank you for that. We're now, if all the panelists could turn their video on, Dr. Izuagwa is now going to lead us in a case discussion, excuse me, on limb lengthening.
Good day, everyone. I'm Dr. Izuagwa from Lagos, Nigeria. I'll be sharing one of the cases I did as an in my early practice as a deformity surgeon. It's a case of a limb lengthening in a patient with Olier's disease. So the girl is an 11-year-old with limb deformities that affected the right forearm, right thigh, and right leg from childhood. The initial review and diagnosis was made at age 5. That was in 2009 when the deformities were noted to be quite significant. She has had a corrective osteotomy then for a severe valgus deformity of the right knee. However, the limb deformities and shortening progressively became worse as growth progressed. Next slide. So these are the clinical pictures and the x-rays done as at the time I saw her initially in 2015. Next slide. So she at the time of presentation, when I first met her, she had an abnormal curvature of the right forearm with significant shortening of 5 centimeters compared to the left. A 10-degree varus deformity of the right thigh and 40 degrees valgus deformity of the right leg. The right lower limb was significantly shorter by the left by 20 centimeters. 11 centimeters was at the tibial level and 9 centimeters at the femoral level. She had a compensatory but flexible equinus deformity of the ankle with an overriding torso hypoplasia. I used a multiplier app to estimate the limb length discrepancy at maturity, which was estimated to be 22 centimeters. That was the total discrepancy she will have needed. So just as a panelist, seeing this case, how would you approach the correction of limb length difference in this child?
So Mecca, that's a really challenging case. There's a substantial amount of deformity that I would want to correct, as well as the foot deformity, and then the length. So those are 3 very difficult things to address, and I usually try and break everything down into component by component. So we have distal femoral varus that we need to address, right? We have tibial shaft valgus that needs to be addressed. We have the equinus deformity, and then we have the limb length discrepancy. So I would work with the family on making a plan for addressment of all of these things. And certainly that distal femoral varus and shortening can be addressed with lengthening and deformity correction at the distal femur. And then the tibia could be addressed with angular correction and lengthening of the tibia. Getting the foot up most likely will take external fixator-based correction as well. So the question is whether you do it all at once or if you stage it. And I think a lot of that depends on the resources of the family and how confident you feel. That much lengthening of the tibia and femur, I would like to separate them if I could.
The other thing I would add in her age group is I would consider early epiphyseodesis on the contralateral side.
Good point.
Yeah, that was great. However, in my environment, people tend not to want you to deal with the non-involved limb at all. So they want you to put channel all your energy into the deformed, shortened limb. So that's a challenge we have around here. Next slide, please. Next slide. So what I did was to apply an Lateral fixator for tibial lengthening and deformity correction with a proximal corticotomy. If I was to deal with this case now, I'll probably have done it differently, but what I did then appeared to work. So she distracted after 5 days of latent period for 174 days. And post-distraction, the ankle was plantigrade, but forefoot was in equinovarus, knee and ankle physiotherapy were commenced throughout the period of distraction. Next slide. So these are the sequences of progressive lengthening she had as time went on. I did a Hox percutaneous tenotomy for the tendon Achilles because I didn't want to put too many frames. Because one, we had a limited amount of frames to use. So I just devised a crepe bandage that could help her to do some active physiotherapy of the limb once the tendon Achilles healed. And this will continue until she achieved that length. You can see. Next slide.
I think that's a really great and inventive way to deal with the equinus that you're inevitably going to get with lengthening as you tension the Achilles. That's wonderful.
Yeah, thanks. So this is sorry for the poor x-rays. We have better films now. So this was those days. So this way progressive lengthening, you can see the degenerated gap forming and the AP and lateral views. Next slide. So this continued until we achieved the length and left her to consolidate with time. Next slide.
And Micah, for that last image, are you worried about the knee joint at that point? I can't tell from the X-ray, but that lateral.
Yeah, the lateral view looks as if the knee was stiff, but it wasn't that stiff. It was just the position the film was taken.
Okay.
So though she had a reduced range of movement, she had knee stiffness and a bit of ankle stiffness after the length was achieved.
Mecca, did you do any soft tissue release at the ankle? Any Achilles lengthening?
Yes, initially I did at the first surgery I did a Hox percutaneous tenotomy.
Oh, I'm sorry.
Yes,
Thank
and
you.
that's why I supported with a crepe bandage. Okay.
I think in terms of that knee X-ray, as long as you can clinically extend the knee reasonably well, then I usually don't worry about that appearance. But if I can't extend the knee, then I am very concerned.
Okay. If we can look from the clinical picture after she took that X-ray, it's not as bad as it looked on the X-ray, actually. But of course, she still had she couldn't extend fully. Next slide. So this was as the bone was degenerated was mature, and you can see the long length of regenerate that was gained over time. So at this point in time, we had finished lengthening and we're in the consolidation period. So I want to ask the panelists, what do you do? We want the tibia correction to be complete before dealing with the femur, or what will you do at this point? Ray.
So at this point, how much have you lengthened the tibia?
At this point, the tibia was 11 centimeters lengthened.
So at this point, your discrepancy is on the femur.
Yes, especially on the femur.
I think it is reasonable, and I can't tell if the foot is reasonably plantigrade, but it seems reasonable to give them some time, because that's a very big intervention. Maybe give them a couple of years and then come back and address the femur in the future. And then in the meantime, give them a lift to balance them out as well as possible. You could, at this point, when you take off the frame, you could put a guided growth plate on the lateral aspect of the distal femur and correct that varus deformity and give yourself one less thing to worry about, and maybe more options in the future. Because if you only have to do a straight lengthening rather than lengthening the deformity correction, it's just a little easier. But that is really predicated on whether you can get good follow-up of that child. If they're coming from very far and you don't trust the ability to see them every few months, then I would not do that.
Yeah, your last point, actually, you're right, because they live in a neighboring country, Benin Republic, so follow-up was a big challenge during that period. And at the same time, they really wanted as short a length of treatment as possible, finances and every other things, schooling and other considerations. So next slide. So I discussed with the family, and we took a decision to start the femoral lengthening while the tibia was consolidating fully. And 2 years after, about 18 months after the initial tibial lengthening, we applied an lateral fixator in the femur and commenced extraction 5 days after the surgery for 3 months. Next slide. So the picture above was her in the theater. She had some ankle stiffness, some equinus, and then some knee flexion. I did a manipulation under anesthesia in theater. Then I applied a foot frame and then a frame in the femur. I made sure I left enough space between the last ring in the femur and the proximal ring so that she could have a lot of physiotherapy during the period of treatment. And next slide. Okay, that was the X-ray following the surgery. Well, this was the first time I was treating a child like this, a child with this kind of pathology. So I wasn't really sure what to get. So I decided to avoid the initial surgical sites where I could have done the osteotomy and done the deformity correction. So I just wanted a virgin bone where I was sure at least I could get a good degenerate. So that was why the osteotomy wasn't done at the cora at that time. Though, of course, if I was to do this case again, I'd probably plant it in the cora and do a deformity correction as well as a lengthening at the same time. So next slide. So these were the last pictures I took. That was after we've achieved lengthening. In the clinical picture, we didn't achieve a full correction of the knee flexion, but the ankle was plantigrade. So even though she had a limb length discrepancy, residual limb discrepancy of 2 centimeters, but she was it appeared more obvious because of the residual knee flexion, but she was able to achieve very good extension with physiotherapy subsequently. Though no thanks to COVID, distance, and some other factors, that was the last time I saw her in the clinic. Next slide. So these were the radiographs of her last visit to the clinic. All the regenerates were well consolidated, and can see the flexion. It's difficult to really know the extent of flexion because the way X-rays are taken in our center, they flex the knee a bit to take radiographs generally, and we don't really get to go to need them. She has a tilt of the knee joint, which I hoped to address later with the residual LLD when she's really mature, but I've not seen them yet. So I've not seen the latest radiograph to make that decision. Next slide.
Hey, Mecca, just going back, it looks like there's some recurvatum of the proximal tibia. So the tibia is trying to get the knee straight, but the femur seems a little bit in procurvatum, if I'm looking at that right. So potentially when you do your last procedure, you might incorporate a little extension of the distal femur to see if that can help her overall knee alignment.
Actually, so it's a varus. That was the AP view.
Yeah.
The first view is it's actually in
left.
Procurvatum.
Okay.
Yes. The one that looks as is Procurvatum is actually a varus, the initial varus that was there.
Okay, I understand.
Yes. Okay. Next slide. So these were general obstacles that I encounter when we're doing this kind of surgery: pin track infections, ankle pains, ankle stiffness, and all that. External fixation index it has displayed the tibia healed faster than the femur, funny enough. Or rather, I left the tibia in place, the tibia frame in place longer than the femur. Next slide. So these were images she sent to me from her place, just to show how much progress she's achieved with the knee flexion. She's actually quite happy. She's really not in a hurry to come to the hospital for follow-up. She's really happy with how she is. So this was how flexing the knee. She could flex up to, according to her, she could flex up to 110 degrees. And she has a better extension now. This was last year, June. Next slide. So, and this was a radiograph she sent to me early this year, the one on the right. So comparing it to how she presented to me 5 years ago and how she is now. I'm still waiting to see her clinically to assess what is left to be corrected. Next slide. So thank you very much for listening. So questions and comments.
Yeah, that's a really remarkable, well, Rich was probably gonna say the same thing. That's a remarkable outcome on an extremely difficult problem. That's really well done.
Yeah, excellent, excellent work. And I think that's a great question I have for the panel is, would anyone consider a lengthening procedure for a 2 centimeter leg length discrepancy?
Oh, no, very rarely would I consider that. They'd have to have a lot of symptoms and have failed a lift. 2 centimeters is sort of the maximum of what most people would consider acceptable.
I would echo that sentiment. I occasionally get a patient that is really demanding about that, but I've not acquiesced, because we know from population studies on large groups of marathoners that a 1 centimeter leg length discrepancy makes no difference for athletic function. So using a small lift of even 1 centimeter in a shoe. So I think, you know, maybe things are changing with internal lengthening nails and aggressive patients, but I just want people as a take home for the panel to say, overall, 2 centimeters is very acceptable. And it's for this young woman, I'm sure it's just continuing with time to work on her joint stiffness. And that's primarily physical therapy and time.
I was just wondering about the femur deformity. Would you have considered including, basically incorporating a nail, you know, especially for the femur, you know, allow you to do acute angular correction, and then you can do your lengthening of a nail?
Yeah, if I was to treat this child now, I probably would have. But then she was, when I saw her, she was 9 years. So I'll be worried about the growth plates at that time too. I can do that now because she's almost mature, if not mature, bone-wise. But at that time, one, I was scared of the pathology. I didn't know what to expect. So I'll probably still do the same and wait until she's mature before I do that. Right now, I'm more confident in putting a nail into the femur joint with the new advances in nail going through the side of the greater trochanter, which wouldn't affect much, cause much much fascial damage. Yeah, that could be considered, and then do a lengthening over nail through that deformity. And so it was help her to have less time in a fixator, yes.
Ray, what are your comments on, new techniques? You're a specialist in pediatrics. I know at the last summer's LLRS, there was quite a bit of new technology for the panelists to learn on lengthening in the femur, but in a more resource limited environment where they don't have the magnetic lengthening nails. What do you think would be the best treatment in say a child between the ages of 7 and 10 that you would feel is the safest method?
Yeah, I think if you don't have access to the magnetically controlled nails, you are looking at external fixation, which I think is tried and true and has done very well. If you wanted to do lengthening over a nail, technically you can put a nail across the greater trochanter down to age 8, males and females. The idea is that the cartilaginous portion of the greater trochanter is essentially formed at that age, and there's not that much more length to be had. It's an apophysis, and so that's the idea. You definitely don't want to go piriformis in a child because of risk of ABN, but you could potentially go greater troch.
And what about the idea of using like a small nail, like an Enders type nail that are readily available, and sort of combining those techniques, because the nail can be small enough to prevent those problems in the femur where the bone will sort of shift and migrate very easily. But in a small child, like a 4 millimeter, a small nail, and then a Lizarov or a monolateral lengthening will go much smoother, right?
Yeah, I think that's an excellent option. That's done in the States and I believe internationally. To put a small flexible nail, it's a great idea. It protects the bone, prevents translation that you don't want, gives it a little bit more stability so that you could potentially get the frame off sooner.
Yeah, great case, Dr. Mecca, and great discussion.
Yeah, I agree. I just really great presentation. I just wanted to bring in a few of the Q&A that's coming in from participants. One that's directly related to the case from Dr. Malaba is, what was the length gained in the case? And the second part of the question is 5 centimeters a good general goal for tibial lengthening?
Okay, we gained a total of 19 centimeters from both the femur and the tibia. The tibia was 11, the femur about 8 centimeters of length gained. So then, I don't know, the second question.
The second part is 5 centimeters a good general goal for tibial lengthening?
Yeah, I think so. 5 centimeters will avoid a lot of problems with joints and other soft tissues. But sometimes it depends on where you practice and your environment. Yeah, but that's a general good rule to follow. Can stage lengthening of 5 centimeters and still have very good physiotherapy to protect the joints up and above and below the limb you're lengthening.
And if you go above 5 centimeters, what would you do, or have to do more than 5 centimeters? I guess, what do you do differently, maybe?
If I have to lengthen a limb more than 5 centimeters, then I'll do a joint spanning frame to protect the joints, either above or below. Either I protect the ankle joint or I protect the knee joint, just to keep it apart while the lengthening process is going on. And after I've achieved that length, I can now remove the hinges that separate it so that physiotherapy can continue. That's really what I do for most of the congenital femoral, mild congenital femoral deficiencies I do now. I lengthen from below, from the distal metaphysis, and but I put a ring in the tibia and protect the knee joint so that it doesn't sublux or dislocate.
Great. Any other comments on that from the panelists?
No, I agree completely on that. You really have to be careful on the joints, as Dr. Mecca has stressed. And then, you know, in these kids, they typically will form very good regenerate bone, but then that's the second limiting factor is what is the quality of the regenerate bone at the osteotomy? You know, if you're looking at poor bone formation, you know you're going to have a long period of consolidation. You would not want to be aggressively continuing to lengthen, and that may be the other factor that is often, you know, the reason that you limit it to 5 centimeters, say. But I think that's the other factor.
Great.
What I would add is don't hesitate to span the adjacent joint, whether it's the knee when you're doing a femur or proximal tibia, or the ankle when you're doing a tibia. Dealing with the flexion contracture of the hip, the knee, the ankle after deformity correction is a difficult problem. So have a low threshold for spanning the adjacent joint, and then just preventing a contracture if you can.
Yeah, great comment.
Yeah.
I was also wondering, the spanning the joint in children, does it also protect the growth plate? If you're going to lengthen, you're going to do a longer lengthening, can you cause a growth plate ablation?
Yeah, you need to protect the growth plates. It might need to pass a thin wire, okay, to hold down the epiphysis so that you don't have epiphyseolysis. That is, you don't start distracting the epiphysis instead of the where you did your osteotomy. Actually learned this trick recently during sessions and LLRS sessions. That you need to protect it. It's quite very possible that you'll be distracting, and then it's the physis that is being distracted and not the your osteotomy. So I agree with you.
Yeah, in terms of growth inhibition, 5 centimeters has been used a lot in children for lengthening because of the idea that you may cause growth inhibition in the future. The data on that's relatively thin. And I think in Emeka's case, that it was totally appropriate to continue lengthening with their full length being determined by the stability of your joints and any contractures of the soft tissues. If those things aren't holding you back, then continuing is reasonable. If you have a social situation where you need to do this all at once. In terms of distracting through the growth plates by accident, the classic problem is in cases like tibial hemimelia and fibular hemimelia, where you're correcting through the ankle joint. You're going to want to put a wire through the epiphysis so that you don't accidentally pull the physis apart when you're trying to distract a really stiff ankle.
Great. There's a lot of great questions coming in. I'm just going to ask one more so we don't get too far behind. But so the question is, with leg length discrepancy, is there a stratified system on choice for lengthening as far as the gap is concerned, or the projected discrepancy upon maturity? So do you have a system based on the degree of leg length deformity that helps you choose what type of lengthening you're going to do. I think, is that clear?
If you have like a very young child and you're meeting a child when they're 2 years of age and they're predicted to have a 20-centimeter limb length discrepancy, then you do want to establish a plan as to when am I going to lengthen them. And a common thing to do is to say at age 4, I'm going to do 5 centimeters. At age 8, I'm going to do another 5 centimeters. Then 12, another 5 centimeters, and make this plan in the beginning so the family can understand and go through with this. That's assuming very perfect circumstances. And again, sometimes if you're dealing with people that are living very far away, you have to modify those plans.
Great. Okay, well, in the sake of time, I want to jump into the next section, which is going to be on bone transport. And if we can have the panelists turn their video off, we'll get going with that. I also will try to answer some of these questions maybe by typing during the talk for all these other questions are coming in. Thanks a lot.
Hello, my name's Ken Thomas. I'm from Anchorage, Alaska. We're going to do a quick bone transport review. My disclosures: I'm a partner in Anchorage Fracture and Orthopedic Clinic and a paid consultant for Johnson & Johnson DePuy Synthes. What is bone transport? Basically, it's moving a piece of bone into an area of missing bone. It's very similar to lengthening in that there's a distraction osteogenesis site, but there is also a docking site after that transport piece has made its way across the segmental bone defect. What are the indications? Basically, segmental bone defects most commonly caused by trauma, infection, or tumor. Preoperative patient evaluation and optimization. Tobacco cessation is very important. Varenicline and bupropion are 2 prescription medicines that can help. Although suboptimal, but still better than smoking, nicotine inhalers, gum, and patches are also available. Any vascular disease should be evaluated and corrected. Arterial ultrasound and CT angiograms are good tests to look for that. Any endocrinopathy, such as thyroid and parathyroid disease, should be identified and corrected. Vitamin D deficiency is very common. All my patients get a 25-hydroxy vitamin D level ordered and at least 2,000 IUs POBID of vitamin D supplementation, more if they're found to be deficient. Malnutrition, battery of tests to evaluate that. High protein diet is essential. Bone transport is a very metabolically active process. It's essential to have a high protein diet to form new bone. In addition, the patient's mental health status needs to be addressed. Depression and self-efficacy are 2 areas of concern. Depression should be addressed and treated. Self-efficacy should be evaluated and coached if possible. Self-efficacy is basically a belief in yourself or self-confidence. Sleep hygiene is also important. If your patient is not getting high quality sleep, they're not going to do well with the transport. And then other social support aspects such as transportation, someone to talk to, family, friends. If they're in an external fixator, how are they going to wear clothes? Who's going to modify their pants? And then how are they going to bathe? All these things need to be addressed. Limb evaluation and optimization. First off, the limb has got to be stable with external fixation or internal fixation. Dead space has to be managed with antibiotic beads and or antibiotic spacers. The wounds have to be clean. In general, you want to debride, and then debride some more. The wounds need to be cared for. The soft tissues must be healthy. Frequent office visits to check the condition of the wounds. And if there's an infection, what is the causative organism? What antibiotics is it susceptible to? What allergies does the patient have? And then you want to consider the route of antibiotics, whether it's oral, IV, or local antibiotic delivery. Education of the patient and the caregivers is essential. Sit down with them and explain the process. They're going to need weekly or twice weekly appointments and x-rays during transport. There's multiple surgeries involved, and I start talking about docking immediately. Docking is a difficult process, and sometimes it doesn't work. They need to be aware of that. Elicit questions and concerns. Consider multiple preoperative appointments. If you're busy in clinic and you can't get to everything, have them come back in a couple weeks. Timing. Really, if the limb is stable and in an X-fix or some type of internal fixation, this is not an emergency. It's an elective case. Make sure that everyone is educated, all their questions are answered, and that the patient is optimized. And really, for me, in my practice, if the patient and or the caregivers are not 100% committed to this, then it's a no-go. We don't do it. All right, let's talk a little bit about docking. There's techniques to improve docking: compression, alternating compression and distraction, bone grafting, bone morphogenetic proteins, external stimulators. Also has been written up arthroscopic debridement of the docking site. And then a couple tips. What I like to do is to distract the docking site either the day before or in the OR, give me some room to work. Debride the docking site, get any fibrous tissue, get the bone edges bleeding, cut the fibula if you need to, and then pack in iliac crest bone graft, and then compress the docking site, and then increase the stability of the construct at the docking site. Here at this docking site, we put a supplementary plate, make sure that everything is as stable as it can be. Let's go through some options for the femur. Here is a proximal diaphyseal femoral bone defect. We've got a monorail, laterally based external fixator with a retrograde bone transport, pretty straightforward case. Here is a distal femoral metaphyseal segmental bone defect secondary to infection, laterally based external fixator with a bone transport over a nail. Here is cable transport in the femur, monorail, laterally based external fixator with cable transport in an antegrade direction. Note the additional pin and stability once docking has been achieved. Radiographs of a similar case. This is the so-called PAPS technique, or plate-assisted bone segment transport. It's the addition of a plate to maintain length while utilizing an intramedullary lengthening nail. Here's a distal femoral metaphyseal defect. Plate is placed, intramedullary lengthening nail is placed, and then antegrade transport, bone grafting. Here's some radiographs of a similar technique used in an actual case. And then, of course, the intramedullary bone transport nail. There's a couple of them available. It's nice. It's all inside, very expensive. Here's a distal femoral defect with an antegrade transport. Bone transport options in the tibia. Here is a proximal metadiaphyseal defect, stabilized with a plate, bone cement spacer, transitioned over to a medially based monorail, retrograde transport. Docking site was bone grafted, fibula was cut. Maturation of the regenerate and healed docking site. Here is a distal diaphyseal defect with a monorail transport over a nail. Really nicely done. Good healing, good regenerate. Here's an infected tibial shaft with poor soft tissues and a retained intramedullary nail. Nail was removed, bone resected, soft tissues improved, stabilized in a stacked hexapod ring external fixator Dead space was managed with a temporary antibiotic cement. Then bone transport, docking, bone graft at the docking site, fibular osteotomy. There's the healed end result. Here's an example of a open tibia fracture, significant comminution and soft tissue damage, multiple debridements, stabilized in a ring external fixator, soft tissues healed, ready for bone transport. This is a medially based monorail with a supplementary lateral plate, retrograde transport. Docking has been achieved with bone grafting. Note the additional screws in the bone transport segment to increase stability. Very nice result. Let's talk about cable transport. Here's a cable transport with a ring external fixator, antegrade for a large distal tibial diaphyseal defect. Here's a cable transport utilizing a monorail, medial external fixator, antegrade, similar concept. And then a ring external fixator, cable transport over a nail. Here is a complex tibia with metadiaphyseal bone loss stabilized with a plate, bone cement spacer. Then, once everything is stable and soft tissues are healed, transitioned over to a long plate and a PAPS technique, intramedullary lengthening nail, retrograde transport, healed and docked. And then the intramedullary bone transport nail, antegrade transport in the tibia. This is just a diagram illustrating the concepts. Thank you very much.
It was a great talk, Dr. Thomas. Thank you. If everyone can turn their video on for the panelists, we're now going to have a case discussion led by Dr. Anthony Mina.
Okay, thank you for having me, and welcome from across the world. I'm Anthony Mushiri Maina. I'm an orthopedic surgeon from Kenya. I'm going to discuss a few bone transport cases with few nuances to it, and make it as practical as possible, especially for resource-limited settings. So, next, I'll start with a straightforward case, cases that we see every day. And this was a 23-year-old gentleman with a trophic gap nonunion after an open fracture. So he presented to us, several months late. And as you can see, our first stage entailed debridement, external fixator, and then an antibiotic cement spacer. And the main thing is to, remove, the dead bone, at the tip that we don't think was very viable, and you ended up with a segmental loss, because we had previous history of infection, put in antibiotic cement spacer. And so the key thing is to go to the second stage. Next. And the second stage actually entailed now doing transport of a nail. And this is where, it makes it, very simple, because you're able to put in a nail, put in a monorail external fixator, and be able to transport. And at the end of transport, and you have good consolidation of regenerate, you can remove in the external fixator and remain in the nail. So the image to the extreme left shows you the proximal corticotomy site. And then distally, you can see the previous two pinhole sites. Those will help you, when you're doing the lengthening. Because this gentleman had two things. He had segmental bone loss, but also had limb length discrepancy. So after 1 month, as you can see in the middle X-ray, the end of segmental transport, and then we ended up progressing with the limb lengthening. And as you can see on the image on the extreme right, you can see it's already docked down there, and then the nail actually is telescoping into the bone. You can see that actually the bone was seemingly, bowing, outward in some valgus deformity, but that was going to be corrected in the next stage. Next. Next slide, please. Okay, so here we ended up saying, okay, segmental transport is done. You know, the lengthening also has been taken care of. So we needed now to be able to protect it because we had not locked distally. We needed to protect that, and so ended up actually exchanging the nail and putting in a longer nail, locked it proximally and distally. And as you can see, there's more regenerative visible on these images at 3 months. Next slide, please. And so we followed him up. You know, we were lucky to have him quite compliant. And as you can see initially, as Dr. Ken Thomas had pointed out, you can have docking site problems. So we kept a close eye on him and followed him up closely. You know, good enough, our reamings, I think during the exchange nailing, you know, helped us. And as you look at the docking site, actually it progressively has ended up healing, and there's good consolidation of the regenerate. Next slide, please. And as you can see at this juncture, you know, you are able to attain good range of motion in this squatting image of his hips, knees, and ankles. And there's a small video to the right. You know, you can play the video a little bit. Yeah, so he's able to walk unaided and, you know, with no limp at all. Good, thank you. Okay, so next.
Sorry to interrupt.
Yes, go ahead.
That was a great case. I wonder if we could just take a minute to do a little bit of, see if anyone has any questions or comments on your first case. I was wondering if you could just comment on the, you know, pros and cons of doing the transport over the nail versus not using the nail.
Yeah, I think that's a good question. You know, one of the things that I've learned over time is that, you know, when you're using, initially when we started doing bone transport, we used to use purely external fixators. And two things that we faced a lot of time in the external fixator and the attendant complications, you know, pin site infections, pin site loosening. And then the second, you know, for me that really makes me like the nail is the docking site accuracy. So you're able to accurately dock where you want and compress as hard as you can. So those two things I think are very, very key.
Great.
Anyone want to add something else?
It is a little bit tricky though, when you're doing a bone transport over a nail, getting the wires and half pins around the nail, it causes a little bit more time in theater. It takes a bit longer. So allow that when you're going in. Don't you think, Dr. Mina?
Yes, that's true. That's true. And then also you have to choose the right size of pins, because if at all you have a small bone and canal, and so and then you put a big nail, you have no space for your pin.
Mm-hmm. Don't make sure you have enough time in theater. Don't rush, because you know you'll put a pin and hit the nail and then have to redo it. It's tedious.
Very true.
Yeah, there's a question here about when changing the nail to a bigger one in the presence of a regenerate that has not yet consolidated, do you ream the nail?
That's a very good question. You know, for me, purely through the regenerate, it's almost like an unreamed nail. I just look for a space with a pilot reamer, so to speak, if you're using the sign system. So, and then, you know, I don't aggressively ream across a regenerate. I don't know whether anybody does anything differently.
I think it's such a case-by-case decision, because, you know, oftentimes these problems come with a failed nail or a failed exchange nailing already. So I think you want to be very careful on making, you know, a definitive statement on whether you ream or not. I think in sort of virgin canal, I don't think if there's not a concern of infection that there would be a problem reaming up through the regenerate. Do the panelists agree on that? An uninfected bone that has not been previously reamed much?
Yeah, I think that's a good point. Also, when you're transitioning to a larger nail, you know, specifically in the tibia, you need to be very mindful of how you ream. You want to monitor where the head of the reamer is, and if you're in the area where there's regenerate, past the head of the reamer without it moving, then get into the diaphysis, start the reamer through. You don't necessarily have to turn the reamer on and run the whole bone. That's where you're going to get into problems. You could blow out your regenerate or cause problems with adjacent areas. You want to be very mindful and look at the tip of the reamer. And if you get into a section of diaphysis that needs to be enlarged, then turn the reamer on. But don't run the reamer through the regenerate. That bone's going to be soft and new. It'll easily take a larger nail without aggressive reaming.
And to that point, that's an excellent point. Nothing could be a bigger disaster than if your reamer binds in your transport segment and causes it to spin. I mean, that's that would be catastrophic for, you know, the disruption of soft tissue envelope as well as, you know, other problems. So be very careful there.
All right, so ream with caution.
Yeah.
I guess on another note is just sort of, there's mentioning of bone grafting of the docking site. Is that something that should be just a routine part of every bone transport, or is it a case-by-case decision?
That would be a good one to throw out to all the panelists. Why don't we just go through, you know?
I have strong feelings in a lot of cases about that.
Dr. Mina, what's your experience then?
I think that's a very good question. When I have a chance, I just bone graft, you know. Yeah, like in this case that I presented is that because we came in to do exchange nailing, you know, and did a lot of reaming and, you know, did it, you know, closed. And so, you know, I expected that, you know, and the reaming was in that transport segment distally. So to be able to get in a longer nail. So did a little bit of some reaming, although not of the degenerate. And so, and I was supporting the transport segment with a pin. And so I think for me, I thought I had gotten some good bone graft there.
I see, from the experience.
Yeah. So, but if I, whenever I am there and see, you know, this doesn't look like, you know, it's throwing any bone. When I'm coming to do any exchange nailing, I have an opportunity. You know, if I respect a part of fibula, I always put it there as local bone graft. So I don't hesitate, you know, to take chance to bone graft.
Any other comments on that?
Okay, one thing I also do, well, most of my patients are kids, so they don't really have that problem. But when I do treat adults too, something I do in place of bone grafting at times, I do the accordion technique, a sequential compression, distraction, compression, distraction. And every time I've done it, it's actually worked very fine. So, because I usually have problems going back to the OR, cost of space and time and finance. But it tends to work very fine too. And I've done it, I use it routinely, but still there are some patients I still have to go back to the OR to bone graft, a few. But that's an option one can also look at, and it works fine.
Great.
Yeah, that's an excellent point, Emeka, that, you know, in different populations can respond differently with the pediatric versus, you know, an adult traumatic situation. I think from my reading, I have typically done a bone graft at the docking site, but the article by Quinan, they started doing that, but with the cable transport, what they're doing is it seems they're resecting more bone to get back to healthier bone. And as long as there's greater than 75% of an intact ring there in the tibia at least, that they've been getting away from doing bone grafting at the docking site. But I would do the principles. They still do a debridement and then, you know, feather the bone and look for bleeding to make sure. And then if there's any question, then they do add bone graft.
Just a comment on that. I don't like to take patients to the theater unintentionally or if I don't need to. So I have tried to get the docking site to heal with the compression distraction accordion technique, and I've had unsuccessful results. And then it's very frustrating to a patient to go through a long attempt at docking only to need another surgery and bone grafting anyway. So I agree with Dr. Mina. I don't hesitate. I talk to them about the docking from the start, and then once we get to the docking site, I usually just recommend going back to the operating room, debriding it, bone grafting it, compressing it, adding stability. This is the most difficult thing. As you lengthen, it gets more and more painful. You're pulling that piece of bone through the limb. So right when you get to the docking site, they've had more and more pain. And it's a really difficult aspect of the whole bone transfer process for the patient. So.
Okay, why don't we do your second case, Dr. Mina, if we have time, and then we'll see if we can get to any more of the questions that are coming through.
Okay, thank you. Nice discussion. So the second case is a 36-year-old lady. She presented to us with an infected Gastilo 3B tibia fibula fracture. The image on the left shows, the casualty image. That's a posterior splint, and then has a huge soft tissue defect and also exposed bone and false smelling dressings. Obviously went in for the first stage. The first stage is basically to control the infection and get good stability, take care of dead space, and also take care of this of the infection and the soft tissue. Sorry. And so what we did is ended up with putting an external fixator, antibiotic cement spacer, and a soleus flap, and shortened her so that our flap is able to take care of that. Next, please. And as you can see on the X-ray on the left side, the AP and lateral, that's the initial one, with the antibiotic cement spacer in situ and the shortened limb and external fixator. Then went in for the second stage. And the second stage is to take care of the segmental defect and also take care of the limb length discrepancy. It would be interesting to know, whether anybody, from this stage will do something different. I know in my resource limited setting, I'll probably just stick with this monorail, of a nail, but I don't know whether, a magnetic nail will work in this case. Rich, Ken?
With a flap and an infected tibia, I think I would have done the same construct, or maybe a hexapod, just so I could have more control and more stability. But I like this construct. I mean, I think the way it was done and started is fine. An internal lengthening nail in this situation with a history of infection and a flap, I'm just not that comfortable with it. And I like to be able to have more control. That's one of the things about the magnetic nails. You sort of, it just all happens inside and you can't really control much. I like this. It's very stable, and you don't mess with the soft tissues much, but yet you still have a lot of control. I like it.
I agree, and I don't have enough experience with the internal lengthening nail and their feasibility in this cohort. Trying to get this, and we're trying to be disruptive, right, and come up with simple solutions for complex problems. So I completely agree on that. I wouldn't look to trying to do anything with an internal transport nail for these complex type of problem.
No, and one other comment here is most people, when they see an antibiotic spacer like Dr. Mina placed, they immediately go to the masculate technique or generically the induced membrane, but don't limit yourself. He is utilizing a antibiotic spacer to help with his soft tissue management, and then have a space for that bone transport segment to go. So this is excellent. Yeah.
Yes. Do maybe for the panel very quickly, I prefer beads, to the block. I know that the block is popular. I like the flexibility of the beads, being able to take them out through a smaller incision. Any other ideas, or any other people use beads instead of a block?
I think beads are, they get this fibrous tissue in and around the beads, which I don't like. With this, I'm sure Dr. Mina had to elevate the soleus flap and then just pull the block out, which is fine. And it leaves a really nice area to transport down into, but I think both are probably fine. I'm more of a block type
person
guy, than beads.
I think the advantage of the beads is you get better antibiotic delivery. So certainly in your early phases of trying to clear an infection, the beads make a lot of sense. I think if you're inducing a membrane, then probably the block makes sense. But for setting up a transport, I would imagine it's really just kind of dealer's choice.
Got it. Thank you.
Okay, I think we're getting a little tight on time, so we'll maybe just finish up this case, Dr. Mina.
Thank you. Next, please. So this is what we did. Did the segmental transport. As you can see, the X-rays on the left side, the segmental transport is coming to an end. And so we need to do the limb lengthening. And so the limb lengthening entailed, removing the distal interlocking screws and then augmenting the distal segment with an extra pin. As you can see on the X-ray on the right side, the distal interlocks are out and the limb lengthening is in progress and the nail is beginning to telescope into the bone. Next, please. And as you can see here, we're coming to the end of limb lengthening. The nail is telescoping further into the bone, and the X-ray on the extreme right, you can see the nail tip right there. Sorry for the poor X-ray quality. You can see the nail tip actually is right into the transport segment. Next, please. And so we went back into theater, exchanged the nail. This was actually around, between attaining the correct limb length, and doing this exchange nailing, actually it was around 2 to 3 months. So we were trying to give time for the regenerate to form and to consolidate a little bit before we came and exchanged. So we came in, exchanged the nail, locked it proximally and distally. And after a few months, we came in and we found that actually there was recoil of the regenerate, recoil of the transport segment. And so you can see there's a recoil gap. And so we said, oh, let's go back in and do some bone graft. Due to scheduling problems, we ended up with some delay. When she came in for admission, and did a check X-ray, oh, lo and behold, there was something right in there at the docking site. There was regenerate forming, there was new bone forming. And so surgery was canceled. And he said, let's follow her up. Next, please. And so 2 years down the line, there she is. No further bone grafting. She has consolidated her regenerate and also consolidated her docking site. And so we came in, removed the nail at her request, and there she is, fully healed. Thank you very much. Any questions, anything to add?
Yeah, that was a great example of the recoil and how, it just like in life, better lucky, than good. So the challenge with a sign nail, because, in these cases, we'll drill a pilot hole and put in an interlock to avoid the recoil is I can't imagine drilling through a solid sign nail. So in that case, if you had that if you have that in the future, you could put a little 2-hole plate, right? Or what are other options to prevent recoil from the panel?
Another thing to consider, I've had that happen to myself, and it hurts, Anthony, when you see that X-ray and the bone transport pieces shot up, and I've got one going right now that it hurts me to look at that X-ray. Another thing to consider is just tell them you're going to put a little X-fix on, do the nailing, and then just put a small external fixator on between the transport piece and the adjacent segment just to hold it there. Then it's nothing inside, and that's another thing to consider. But there's so much stuff going on in these cases. They're so complicated, and there's infection and social issues and nutrition and all these things. And you got to remember that thing can snap back once you take everything off.
Yeah.
Well, thank you, Dr. Mina. Thank you to all the panelists for a really phenomenal webinar. I know I learned a lot. I wish we had more time to keep going through those questions coming in, and maybe after the conclusion of the webinar, we can try to address some of those by email. But just to respect everyone's time, we're going to wrap things up, and we'll finish with some closing remarks from Dr. Richard Coughlin, who was the founder of IGOT. Thanks, everyone.
Well, greetings to everyone from the Orthopedic Trauma Institute here at University of California, San Francisco. Many congratulations, really, to all the faculty for their informative work and on this very clearly complex topic. So it's just the beginning of discussion, just the beginning of sharing ideas, and I'd like to again congratulate them. And many thanks to all the participants for joining for this webinar. And as a reminder, this is recorded and will be available both at IGOT portal and Signs Hub for further exploration to this topic. I'd also encourage you to please send along your critiques, observations, and more importantly, suggestions for future topics through this interesting webinar mechanism. So with that, I'd like to bid everyone a fond adieu, and we'll very much look forward to seeing you in the near future.